Welcome to the third module in the Clinical Faculty Pedagogical Knowledge for Undergraduate Medical Education program. This module will summarize teaching strategies that are used in clinical education and provide evidence of their effectiveness in promoting desired learning outcomes. The strategies we will review include procedural skill development and the 1-minute preceptor. SNAPS is an acronym for Summarize, Narrow, Analyze, Probe, Plan, and Select. Snippets are a strategy for developing a 20 to 30 minute focused teaching tool. Medical education has always included training in procedural skills. Most of the literature on developing procedural skills in medical education is about surgical training, but successfully completing procedures is important for any area of practice. The relationship between cognitive abilities and task performance over the course of learning has been a classic issue in psychology dating back to Thorndike in 1908. The surgical education literature reports that spatial ability is an important predictor of surgical procedure performance. Performance on testing that measures complex visuospatial organization was a more reliable predictor of surgical skill than either psychomotor ability or personality factors, as described by Keckner et al. In 2006. Keener et al. In 2006 suggests that novices begin with a wide variety of spatial and general reasoning ability, but as novices move through a multi-session learning program where they practice, receive feedback, and gain experience, all participants eventually become proficient. Surgeons are not born, they are made. This can be said about any procedural task that must be learned in the medical profession. Understanding how to teach procedural skills is important to a clinical educator who may have to assist a learner gain proficiency in tasks ranging from entering information into an electronic medical record to performing complex surgical procedures. The era of see one, do one, teach one is attributed to William Stewart Halstead, MD, who was one of the founders of the Johns Hopkins Hospital, where he pioneered strict aseptic technique in surgery, use of anesthetics, and developed surgical techniques. He founded the American System for Residency Training in Surgery. Surgical training began with an apprenticeship model where trainees worked alongside master surgeons. Over the past decade, safety concerns for patients moved the initial steps in procedural training from the operating room to the simulation laboratory. Simulation-based education is an instructional technique that provides opportunities for learners to gain procedural skill competency without the risk of harming patients, as described by Sawyer et al. In 2015. Sawyer et al. Propose an evidence-based pedagogical framework for procedural skills training. The 6-step procedural skills pedagogical framework includes learn, see, practice, prove, do, and maintain. Teaching and learning procedural skills is divided into 2 phases, the cognitive phase and the psychomotor phase. During the cognitive phase, learners develop an understanding of the procedure itself, including the indications, contraindications, and motor actions required to accomplish the procedure. The cognitive phase includes 2 subphases, including conceptualization and visualization. The conceptualization subphase includes strategies such as assigned reading. The visualization subphase, the instructor demonstrates and models the procedure for the learners using both verbal and nonverbal approaches. Successful completion is documented by testing. The psychomotor phase includes practicing the procedure in simulated conditions while learners receive reinforcement of accurate performance and correction of errors. Once proficiency reaches a defined level, a clinical skills assessment is done to prove competency. Then the procedure is carried out on a patient with direct instructor supervision. This is the transition from simulation to actual clinical practice. Performance-based assessment assures the learner is progressing to where he or she can perform the procedure independently and safely. Once training is completed and the learner can perform the procedure independently, the process to maintain competency and proficiency helps to maintain patient safety long term. Levy et al., in their 2016 article, describes any procedure as a complex behavior that is constructed from sub-behaviors. When sub-behaviors or component tasks of the larger procedure are understood, demonstrated, and practiced in a specified order, then the procedure is carried out accurately and effectively. Operant learning permits instructors to reinforce desired behaviors, accurate reproduction of the behavior, and assure accurate performance in the future. Operant learning occurs best when conditioned reinforcement is imparted in a way that is free of language and free of judgment. The challenge in medical education settings is to identify ways to signal conditioned reinforcement that does not involve language or, more importantly, judgment. Levy et al. Selected tying a locking sliding knot and drilling a hole as two important manual skills that orthopedic residents need to master in simulation prior to moving into the operating room. This illustration from the article shows how the steps needed for tying the knot were broken down into component sub-steps and how the steps are ordered in a way to precisely produce the desired outcome. The study and control groups consisted of first-year orthopedic residents, first and second-year non-surgical residents, and first and second-year medical students. The study group participants were provided scripts for performing the procedure and operant feedback in an acoustic form, a handheld clicker device. The control group was taught using demonstration alone. The clicker approach to operant learning has been used in training people such as football linemen, golfers, pole vaulters, and dancers. Participants should understand that this method of providing feedback is intended to reduce criticism, reprimand, public correction, and other punitive methods that may come unintentionally with verbal feedback alone. Negative feedback can interrupt or delay learning. We can look at procedural skills development strategies and compare them to learning theories and perspectives. Behaviorism is an important perspective for procedural skills development, as most procedural skills require the clinical educator to be in control of the learning experience early in skills development. The outcome is measured by how closely a learner reproduces the desired behavior. The learners achieve proficiency as the clinical educator provides both positive and negative reinforcement for observed behavior. Procedural skills in medicine requires the learner to not only perform the skill accurately and efficiently, but to also understand why the procedure is done, what the indications, contraindications, and alternatives might be for a given procedure. These are the cognitive aspects of learning the procedure and are developed in parallel or before the behavioral aspects. When the clinical educator demonstrates the procedure, the clinical educator models the desired behavior as understood in the social cognitive approach. Social constructivism applies when the learners and clinical educators function in the zone of proximal development, where learner knowledge and skill is taken from cannot perform to a level where learners perform independently. Often new skills are built upon older skills through scaffolding. If learners are novices performing a task, as proficiency grows, the learners appreciate maintenance of the status afforded them as adult learners. The next teaching strategy we will explore is the 1-minute preceptor, often called OMP for short. Clinical educators often spend significant amounts of time teaching colleagues and a variety of learners while carrying out clinical practice responsibilities. Educational research in clinical medicine recognizes the value of specific training and educational methods for clinical educators. However, the time necessary to provide effective programming is lacking. OMP was designed as a brief intervention in teaching that can be efficiently delivered and assessed for effectiveness in clinical teaching settings. The OMP model for developing clinical educators is popular and widely used to improve teaching skills. OMP was originally designed for clinical educators working in busy ambulatory practices to facilitate efficient teaching and learning. Fernie et al. In 2001 conducted a study to investigate the effect of the OMP on teaching behavior. This study measured the effect of an OMP program on resident physicians working in a tertiary referral hospital and a Veterans Administration medical center, both affiliated with the University Medical Center in Ann Arbor, Michigan, and San Francisco, California. These are the 5 components of the OMP teaching model. The model defines these 5 micro-skills to help the clinical educator mentor and guide the teaching interaction. The OMP teaching model can be understood easily. Usual faculty development for groups of clinical educators can be done in one session lasting about 1 to 2 hours if focused on a few teaching behaviors that are commonly used and easily performed. The 5 micro-skills are described on this slide. In a clinical teaching situation, a clinical educator asks a learner who has seen a patient to analyze and then describe that patient encounter using the 5 micro-skills. The clinical educator asks the learner to make a commitment to what the diagnosis might be and what the plan of treatment could entail. Next, the clinical educator asks probing questions to understand the learner's knowledge base and reasoning process. The clinical educator explores general principles and important take-home points, or clinical pearls, with the learner to improve future performance. To finish, the clinical educator provides reinforcement for what was done well and constructive feedback with recommendations for improved performance. The next few slides present components of the 5 micro-skills as seen from the point of view of the learner. In this study, medical students provided feedback to the resident physicians regarding their perception of how well the residents addressed each of the 5 micro-skills. The survey questionnaire assessed how the medical students functioned as learners while their resident physicians applied the micro-skills. These questions give clinical educators an opportunity to see how explicit their teaching should be to assure students are actively engaged. For example, clinical educators should ask learners what is their differential diagnosis, what workup should be done, and what is their treatment plan. The learners should feel involved and invested in decision-making process. Clinical educators should form their probing questions in a way that reveals a learner's reasoning processes and baseline knowledge while remaining respectful of the learner. Clinical educators should take advantage of the opportunity to expand a learner's knowledge base and thinking processes by adding knowledge to the conversation that the learner has not considered. The purpose of including general rules is to increase knowledge base and future performance for learners. Feedback should include both positive aspects of what was done correctly, what areas need improvement, and importantly, why correct performance was correct and incorrect performance needs improvement. Frequent feedback is valued by most learners. The 5 micro-skills model benefits learners by providing opportunities to improve skills, such as performing physical examinations, and motivating outside reading. Clinical educators and learners should actively seek opportunities to demonstrate improvement. With the 5 microskills model, the clinical service workflow process can be more organized and patients can be seen more efficiently. Taken together, the impact on individual learner experience and the overall workflow of the clinical setting can improve teaching effectiveness without compromising workflow or patient care. Gallagher et al. In 2012 understand that, quote, clinicians want to be able to offer students quality learning experiences without significant disruption to their clinical work, close quote. Medical students consider learning from clinicians in clinical settings to be essential to their educational process. Clinical work can be busy, unpredictable, and at times take priority over teaching. Clinical educators offer quality learning experiences without major disruption to clinical care. This article defines what clinical educators need to address when applying OMP in their teaching practices on clinical services. Building on the 5 microskills that define the OMP, Gallagher et al. 2012 shapes the conversation between a clinical educator and his or her learners using these 5 key principles that work in parallel to the 5 OMP microskills. Since time for teaching is constrained by the needs of the clinical situation, making the teaching as efficient as possible is a goal within the OMP model. Selecting topics that come up frequently in the clinical practice setting is important. This approach will provide many opportunities for learners to explore their thinking, demonstrate their understanding of the selected topics, and reveal opportunities for improvement. Clinical educators can be more efficient building on core principles that occur and reoccur when common clinical conditions are seen in a series of patients. Gallagher et al. Provides a list of 5 suggestions for groups of faculty to work collaboratively using the 5 microskills of the OMP model. These 5 suggestions also work in parallel to the 5 OMP microskills and encourage clinical educators to work together, developing and improving their teaching skills. The 5 step microskills model of clinical teaching first appeared around 1992, as reported by Fernie et al. In 2001. Here, the 5 microskills were used by family practice clinical educators with their resident physicians as learners, as described by Neher et al. In 1992. The OMP model continues to be used in many medical education professional settings, such as inpatient medicine, dentistry, pediatrics, emergency medicine, and nurse practitioner education. Walpaugh and colleagues introduced SNAPS in 2003. SNAPS is a 6 step learning centered model that requires both the learner and clinical educator to understand and apply the framework. When carried out as intended, SNAPS places the responsibility for directing the learning encounter onto the learner. Given this level of responsibility, clinical educators might consider using the SNAPS model for more advanced or experienced learners, again as described by Walpaugh et al. In 2009. The 6 step process that makes up SNAPS begins when the learner presents a case to a clinical educator. The learner summarizes the patient's history and findings, then narrows the differential diagnosis to 2 or 3 possibilities. The learner discusses his or her analysis of the differential diagnosis. At the 4th step, the learner asks questions to gain additional information and insight. Together, the learner and the clinical educator plan for the patient's management. They will agree on a case-related topic that the learner will explore as part of a problem-based, self-directed learning approach. SNAPS is an acronym for Summarize, Narrow, Analyze, Probe, Plan, and Select. Pascoe et al. In 2015 compares the 1-minute preceptor, or the OMP, and SNAPS as clinical teaching models, and then discusses how to adapt both teaching models for inpatient settings. OMP and SNAPS were developed for outpatient clinical settings. These authors report the OMP and SNAP strategies were equally useful for inpatient and outpatient settings. Pascoe et al. In 2015 described the OMP as driven by the clinical educator who uses steps 1 and 2 to identify the learner's individual needs, followed by teaching that addresses these needs. OMP is efficient. This teaching strategy does not add extra time to a patient care encounter. OMP is helpful for teaching disease-specific points and differential diagnosis that go beyond the traditional teaching strategies such as history taking or case presentation. Clinical educators are better prepared to assess learners and provide feedback using OMP. The OMP strategy can be applied by clinical educators with varying levels of teaching experience. This model has been used by new resident physicians teaching medical students as easily and effectively as experienced clinical faculty. Learners respond favorably to OMP as a teaching strategy compared to traditional strategies. Inexperienced learners respond favorably to the direction they receive from clinical educators. The clinical educator should understand OMP. The learner is not required to do so. SNAPS changes the focus of the clinical learning experience to learner-centered and learner-driven. Both learner and clinical educator should know the SNAPS strategy. The clinical educator does not have an active role until step 5, when the learner and the clinical educator collaborate on a plan of management for the patient's care and select a topic for the learner to explore. Clinical educators can strategically begin with OMP with new learners and then move to SNAPS as the clinical educator gets to know the learners. Secchi et al. In 2016 investigated the learning outcomes of resident physicians working with preceptors at 2 hospitals. Participants were randomized to one of 2 groups, where one used SNAPS and the other OMP. Meaning units were defined as discussions that included differential diagnosis, questions and uncertainties, treatment plans, and learning issues. Learner satisfaction was assessed. SNAPS produced an increased number of meaning units and a greater level of satisfaction in clinical encounters compared to OMP. These results support an approach where clinical educators begin with OMP when teaching new or inexperienced learners and then move on to SNAPS as progress is made. Zeidman et al. In 2015 offered the opinion that OMP and SNAPS for inpatient teaching offer challenges but important opportunities to improve teaching and learning. Snippets were developed at the University of Nevada School of Medicine in 2007 as a strategy to meet faculty development and accreditation requirements. This institution needed an efficient strategy for delivering faculty development in departmental meetings with residency training programs. Since then, snippets have been incorporated into the faculty development strategies at the University of South Alabama Department of Pediatrics, the Icahn School of Medicine at Mount Sinai, and the George Washington University School of Medicine and Health Sciences Department of Pediatrics. Workshops on using snippets in faculty development have been presented at national meetings such as the Association of American Medical Colleges, or the AAMC, and the Accreditation Council for Graduate Medical Education, or ACGME. Bar-On and Konopasek in 2014 define a snippet as, quote, a small part, piece, or thing, close quote. Snippets are short, limited to 20 to 30 minutes, that focus on a single overriding communication objective, or SOCO. The SOCO is a topic or skill that can be taught in the 20 to 30 minute time frame and is relevant to the individuals that participate in this session. The snippet was developed for faculty development as many of the other faculty development strategies such as workshops, seminars, courses, longitudinal programs, or online learning required considerable amounts of time. Lack of time is an important limitation to participation in any educational activity associated with clinical practice and teaching. As a strategy for faculty development, the snippet offers a brief session that can be given during structured time, such as a scheduled meeting. Snippets are not intended to replace formal learning or experience, but can provide a preview to long-term, more detailed educational experiences. Snippets are highly structured tools that are made up of 10 PowerPoint slides, as most clinical educators and learners are familiar with the PowerPoint format. The first slide gives the title of the presentation, the second lists the learning objectives for the activity, and the third includes the important points the activity is designed to impart. There are the key learning objectives or the take-home points. The balance of the snippet presents some activity, preferably interactive, that promotes application of the new knowledge or skill. Debriefing after the activity or some form of discussion is important to relate experiences and reinforce the take-home points. Citations are recommended to assure that the new knowledge or skill presented in the snippet is evidence-based. Baron and Konopasek in 2014 describe 4 basic steps for developing snippets. The first step for a faculty development activity is to select an educational topic or skill to be taught, such as OMP or SNAPS, and then conduct a literature review to create an evidence base for the presentation. The second step is to determine the learning objectives and the key points to be presented. The third step is to select an activity that can include a case study, role play, chart review, a demonstration, a video clip, or a game. The final step is to emphasize again the take-home points and that the participants understand the take-home points. Behaviorism provides the structure for teaching strategies such as OMP, SNAPS, and snippets to work. These strategies have clearly defined roles for clinical educators and learners with expectations for all involved in the learning activity. Cognitive development is evident when a clinical educator moves a learner from the OMP strategy to the SNAP strategy as the learner gains knowledge and confidence in managing patient case presentations. Along with behaviorism and cognitivism, social cognitivism is evident as learners observe and reproduce behaviors in the OMP and the SNAPS models. Social constructivism is evident as the learner and clinical educator together construct a learning environment that allows both to form an agreed upon model for their environment. For example, through either the OMP or SNAPS approach, both agree when a patient's history, physical examination, and laboratory testing means, and agree what next steps are appropriate in the patient's care. The final S in the SNAPS strategy requires the learner and the clinical educator to select a topic for the learner to explore in depth. The selected topic can be given by the learner in the form of a snippet. Snippets can be useful tools for clinical educators to share specific information with learners. For example, the clinical educator can make a snippet about OMP or SNAPS for the learners to review before a scheduled clinical session. Clinical educators and learners can use snippets in their social constructivist approach to learning and teaching. Teaching and learning in the clinical setting can appear to rely on luck. Will we have appropriate patients with problems that match the knowledge, skill, experiential, and professional developmental stages of our learners? Clinical educators may be scheduled with different kinds or levels of learners during a clinical practice session. For example, the office might have medical students assigned one day, junior residents another day, and senior residents on yet another day. If a clinical educator is supervising a service with more than one level of learner, the task of matching clinical and educational experiences to each learner's level and experience can be a challenge. For example, an inpatient ward service can have an attending physician, a fellow, a few residents, medical students, and nursing students. How does the clinical educator structure the session so all learners learn and patients receive the care they need efficiently and safely? Engaging multiple levels of learners applies social constructivism theory to understand how clinical educators can structure their learning environments for multiple levels of learners in the workplace. Engaging different levels of learners is very similar to the application of behaviorism, cognitivism, and social cognitivism we encountered when looking at OMP and SNAPS. Here we see social constructivism in action when we imagine a structured learning environment populated by learners and more knowledgeable others as defined by the zone of proximal development. We see learners of different levels being helped and helping others to move from their level of current knowledge and skill to a higher level within this framework. Shen et al. In 2015 carried out a qualitative study using semi-structured interviews with 19 clinical educators who teach multiple levels of learners in their clinical practice. The transcripts of the interviews underwent thematic analysis with coding. The conclusion was that clinical educators with experience, those described in this article as excellent clinical teachers, describe strategies these educators use matching available learning opportunities to the developmental levels of learners while maintaining learner engagement and safety. These strategies improve learning in the clinical workspace. Shen et al. Outline strategies for adjusting teaching for multiple levels of learners. The three major areas are 1. Sequencing learning experiences, 2. Selecting learning activities, and 3. Defining teacher responsibilities. Sequencing learning experiences includes adjusting teaching content, assessing case complexity, and tailoring expectations. Selecting learning activities includes assessing the developmental level of the learners, encouraging continuity, and building challenge into the experience based on learner developmental level. Teacher responsibilities include balancing teaching and clinical responsibilities while maintaining patient care and safety. Shen et al. Reported for novice learners, such as medical students, the focus should be on pathophysiology. For interns, the focus should be on acute management that includes contingency planning for complications. For residents, the learning focuses on team management teaching. With advanced learners like senior residents or fellows, questioning might include what evidence exists to support a treatment or why a certain imaging modality was selected instead of another. With advanced learners, it is appropriate to explore what are the clinical outcomes the learner anticipates. For novice learners, select cases that act as close as possible to paradigmatic examples, cases that best exemplify what is common for a given disorder, to reinforce in the learner's mind what are the key components of a given diagnosis. Present novice learners with classic cases of a given diagnosis. For novice learners, break a complex procedure into component steps so that the learner can meaningfully learn the procedure over time in a logical progression from start to finish. Clinical educators need to think about what combination of learner, patient, and patient family members will produce the best experience for the learner, the patient, and the family. Clinical educators adjust their expectations of learners based on guidance from educational institutions or national organizations regarding defined learning outcomes. Clinical educators should be provided guidance from these organizations regarding expectations, as expectations do change with time. Expectations should also include how mid-level learners supervise and teach novice learners, and how advanced learners teach and supervise all learners to determine where overall expectations for the team are defined. Experienced clinical educators can often perform a mini assessment of where each learner is in relationship to what would be an expected benchmark for an average learner at that level. The reporter, interpreter, manager, educator, or RIME method started in 1987 at the Uniformed Services University of the Health Sciences F. Edward Herbert School of Medicine. RIME was refined further at the University of New Mexico School of Medicine in 2002. The original purpose of RIME was to evaluate medical students progressing through their educational processes from the level of a reporter to the level of an educator, as described by Ogburn and Espy in 2003. From Shen et al. 2015, learners are classified as novice, mid-level, and advanced. As a framework, the definitions of reporter, interpreter, manager, and educator, as defined by Espy et al. In 2007, can be expanded to fit the scope of a patient care team that consists of medical students, junior residents, senior residents, and fellows. Medical students can be assigned tasks and a level of responsibility consistent with a reporter as novice learners. Junior residents can be assigned tasks and responsibility consistent with an interpreter as mid-level learners, and senior residents and fellows can be assigned tasks and responsibilities consistent with a manager as advanced learners. Fellows and faculty function as experts for both skill level and responsibility, so are educators for a RIME framework. Over time, as we would expect in social constructivist learning environment, reporters will progress towards becoming interpreters, interpreters to managers, and managers to educators. The greatest impact clinical educators have on learners occurs over time. The process depends on faculty members who understand that providing meaningful educational experiences is an essential component of the faculty member's role as the clinical leader on the service. Clinical educators begin with a group of learners and then advances the learner group as clinical educators become familiar with where the learners are in their process and where they have been. Educators then guide the learners into the next appropriate steps in their learning, guided by a reasonable expectations. When clinical educators and clinical team leaders sign out to each other, the discussion includes information relevant to each learner on the team in addition to each patient. This allows new clinical educator to build on and continue with the learners on the team rather than starting from scratch. Part of assessing learner performance and progress is an eye on moving learners along their own individual trajectories as learners. Clinical educators are always thinking about how day-to-day learning activities are moving learners along to achieve learning goals. An important aspect of supporting that process and progress along a trajectory involves providing individualized learner encouragement. Skilled clinical educators consider their relationships with their learners as a contract. This contract involves assisting the learner to achieve immediate goals, such as getting through a given rotation, but may include larger goals, such as becoming a competent physician. Clinical educators feel a strong commitment to help their learners to become competent and skilled clinicians. This commitment to learner success is guided and tempered by a keen interest in patient safety and well being. In a sense, the learner becomes a reflection of a clinical teacher as a professional and caregiver. The responsibilities of clinical educators to their learners and their patients are huge. This is a summary of the practice points from the Shen et al. 2015 article. These practice points define a standard for excellent clinical teachers that is aspirational for every clinical educator every day she or he teaches. Clinical educators are devoted to providing an optimal learning experience for learners of all types, levels of experience, and levels of ability, while giving equal devotion to patients and the delivery of safe medical care. This reinforces the important difference between a clinical educator and a content expert. Clinical teaching is most effective when educators strategically apply learning theories and adult learning perspective. Procedural skills involve behaviorism approaches, as the procedures we often teach must be performed accurately and efficiently. Snippets apply cognitive approaches to increase learner engagement with content and development of a greater knowledge base that builds on or scaffolds on previous knowledge. The OMP and SNAP strategies employ social cognitive approaches where educators and learners interact in ways that allow educators to act as role models for learners. Learners have opportunities to demonstrate knowledge and skill, and educators provide reinforcement and actionable feedback. Teaching with different levels of learners employs social constructivism approaches as the clinical educator constructs the learning environment to serve the educational needs of the group as a whole and each learner as a unique individual. Adult learning reminds educators that regardless of the experience, knowledge, developmental level, or skill of learners, meeting the needs of adult learners includes meeting expectations in a respectful environment.